All right, good morning, everyone. Thank you for joining us this morning. We have over 200 folks across Colorado registered to join us. We'll just wait a moment while people are being let into the webinar. So for our panelists, you can see under participants, the number under attendees is growing as folks are calling in and joining the webinar. Thanks for joining us this morning. We'll just wait another moment while folks get logged in. All right, we're up to 96 participants, so let's go ahead and get started. Hi, my name is Nina Bastin. I'm a program manager at the Colorado Health Institute, and I'm here this morning to help facilitate a discussion with the community around the ACC alternative payment model for primary care, as we call APM 1. Thanks for joining us this morning. I am here with my colleagues from the Colorado Health Institute, Ashley Brown, who will be your chat moderator today and answering questions in the Q&A. My colleague Kimberly Fu is working our production backstage and will also be supporting us this morning. From the department, we have folks from the Cost Control and Quality Improvement Office. We have Charlotte Christ, Dr. Peter Walsh, Zoe Pincus, Nicole Nyberg, and Jed Ziegenhagen, who you will be hearing from throughout our presentation today. A quick glance at our agenda for this morning. So we'll spend the first few minutes going over a couple housekeeping items and the goals of the APM program. We will spend the bulk of our session today talking about proposed program updates that the department has been working on and would like to share with you all for your feedback and thoughts. We'll spend a few moments touching on some progress from stakeholder recommendations from this process last year. So the Colorado Health Institute worked with the department throughout 2021 with stakeholders to work on some program updates, and that the group had some great suggestions. We want to just circle back on some of those and give you all an update on where the department is at. And then we will try to reserve the last 15 minutes for public comment for anything that we did not get to touch on in the session today. A few housekeeping items this morning. We will be using the online tool Mentee. So if you've joined us in years past, you'll be familiar with this. You'll need a new browser window or a smartphone to participate. So if you want to go ahead and kind of get that ready, we'll be doing that in a few minutes as we get to the discussion. If Mentee is not working for you today, that's okay too. You're welcome to submit answers in the chat box through Zoom. At any time throughout today's presentation, you can ask a question to any of our presenters by selecting Q&A at the bottom of your Zoom screen. You're welcome to also use the chat function if you so desire. We would love for everyone to use the Q&A, as that collects all the questions really neatly as well as the answers, and is kind of a best practice for everyone to be able to see the information. And then, as I mentioned, we will be reserving time for public comment at the end. Today's meeting will be recorded and posted to the department's APM website shortly after the meeting. Following this meeting, you can continue to think about some of the things that we're talking about today. If you want to talk to your colleagues and submit some additional feedback to us, you're welcome to do so. You can reach our Colorado Health Institute team at focusgroups@coloradohealthinstitute.org. We will be manning that email for the next few months, so feel free to continue to contact Team CHI through that email address. And now to kick us off, I'm going to pass to Dr. Peter Walsh to share a little bit about the APM program.
Well, first of all, I'd like to say thank you all for attending. I'm Pete Walsh. I'm the Chief Medical Officer of the department. I serve with Charlotte Christ, our CCQI Office Director, and the others from HCPF on our team. like to begin just by briefly outlining our mission, which was modified about a year and a half ago. But as you can see, it's improving healthcare equity, access, and outcomes for people we serve while saving Coloradans money on healthcare and driving value for Colorado. And pertaining to this conversation in particular, we are very focused at the department on trying to improve health equity. And we are also focused on providing value in healthcare, which includes both in quality is very critical to us, and value in terms of cost is important as well. Next slide, please. I'd like to outline briefly what our goals were and are with APM 1. And you can see the 3 bullets there, but I want to just, you can see highlighted, one of our key objectives was investment in primary care, and that remains so. To the value proposition, we want to reward performance and introduce accountability for outcomes. And we also want to improve access to primary care for our members. And finally, a key objective of us as we're moving forward is to align this program with other payment reforms underway with the department. And with that, Nina, unless there's any questions, I'll hand it back to you.
Thank you very much. So we worked with the department to develop an APM 101 webinar, which kind of introduces the program, some of the basics around how it works. This was sent out to everyone who registered to participate in these community forums, and is also posted on the HCPF APM 1 website. We're not going to spend any time this morning kind of talking about what the APM 1 program is. So if you didn't get a chance yet to review that webinar, it's only 12 minutes long. I encourage you to do so afterwards. It may answer some questions that you have about how the program works. Additionally, I want to mention that a communication went out earlier this week to all primary care providers participating in the APM 1. That communication contained information about rate adjustments. It is looking for, was a call for volunteers to participate in APM 2, which is the evolution of APM 1. So just want to plug that as well. For primary care providers, you should have received that communication, and would like to call your attention to that as well. So this morning, around proposed program updates, we want to touch on 3 topics that the department has raised around points for pediatric well visit measures, around how primary care medical providers earn enhanced rates through this program, and also around eligibility for participation in the APM 1 program. Then before we close, we want to touch on 2 recommendations from last year to share some updates with you all around addressing racial and ethnic disparities through this program, and capturing care for all attributed patients. Covered in future forums throughout the next 2 months will be measure sets, including measure selection, point values, and measure specification for the program, as well as program data. What we're not going to be talking about in these community forums are anything related to program eligibility, attribution methods, or benefits like telehealth, excuse me. All the discussion from the series of 3 forums that we have will be summarized by the Colorado Health Institute into a final summary memo that will be shared with the department, that will also be made publicly available on the HCPF website. So let's go ahead and dive in. We're going to start with our program updates, and I'm going to turn it over to Zoe Pincus to kick us off.
Good morning, everyone. Thank you, everyone, for joining us this morning. I know it's early for some and not early for others. So the first thing we wanted to discuss today was, it came to our attention earlier this spring that both the well child visit measures, the 0 to 30 month, and then the child and adolescent well visits, were underreporting the well visits that were taking place. And well visits, so the well visits that took place with a non-physician provider, so your nurse practitioners or physician assistants weren't being captured. And in HCPF's definition of primary care medical providers, they definitely should have been included. So IBM is in the middle of making this fix, and it should be corrected by our next data run and available to PCMPs in November. However, because the fix has not been completed and will only fix the data moving forward, the department has proposed that we award PCMPs who chose either of these two measures in 2021 and 2022 full points. It is a mandatory measure for 2022, so we do not want to penalize and hold any PCMPs accountable to either of these two measures until we can be sure that the data being captured is correct. Next slide, Nina.
All right, thank you, Zoe, for introducing our first topic for discussion this morning. So now we want to turn it over to the crowd and hear from you all what you think about the department's recommendation around awarding points here. So this is where we're going to use Mentee. So if you could either open up a new browser window, or you can do this on your smartphone, you'll want to go to www.menti.com and use the code 2662-2807 to access the Mentee survey. The question that we have for you here is, do you agree or disagree that HCPF should award full points to primary care medical providers who selected well-child visit measures in the 2021 and 2022 program years? So if you're not able to use Mentee for any reason, as I mentioned earlier, feel free to chime in the chat and share your opinion there. But there is, if you open up Mentee, there will be a scale for you to select how much you agree or disagree with this statement. And we have Brian has raised his hand. So if we want to go ahead and unmute Brian's line, if he has a question, we can go ahead and take that while folks are chiming in the Mentee.
Hi, Nina. I think there were some people that wanted the code again.
Oh, sure. Yep, absolutely. So the code is 2662-2807. We'll also drop that in the chat in case you're on the phone. So that's menti.com, MENTI.com. The code is 2662-2807.
I think there's also some concerns that the question's not aligning with what's showing on the slide.
Thanks for calling that out, Zoe. So Kimberly, if you've got the Mentee up, if you want to go ahead and flash to that slide, and we will flip over to her browser window to show the Mentee.
And if people in the meantime just also want to put your feelings in the chat, in the Q&A or the chat, that works too.
All right, well, Kimberly or Ashley, if you want to unmute, I know Brian had raised his hand, we could get him, and also Dr. Walsh, if there's something you wanted to share, go for it.
I was just going to encourage you to call on Brian.
Okay.
Oh, yeah. Sorry, this is Brian. I'm having issues with the Menti. There's no way for me to answer the question. I see the picture, but then there's no sliding scale. It just says submit.
Okay.
Right?
Well,
I'm not sure how to answer.
Menti is not having a great morning, I guess. So why don't we go ahead and skip this one for now? We'll do some work on the back end to see if we can figure this out before we get to the next question. In the meantime, would love to hear from folks who disagree with this. If you'd like to raise your hand and share with the group, or if you'd like to use the chat function, make sure that if you are sending a chat that you send it to everyone, that you make that selection instead of just the hosts and panelists, so that all panelists and attendees can see your chat. We'd love to hear from folks who are not feeling great about this recommendation that the department is putting forward. And thanks, Brian, for flagging that for us. So we'll just pause here for a few moments to hear from anyone who is not feeling great about this recommendation. And again, the recommendation that Zoe presented is that the department should award full points to primary care medical providers who selected well child visit measures in 2021 and 2022. And I'll actually just go back to that slide so that you can see what the issue was around why this measure wasn't working properly.
Nina, I'm going to go ahead and start with Stephanie, who has her hand raised.
Oh, sorry. I just wanted to let you guys know that the chat function is not working, only the Q&A function. But I do strongly agree with awarding full points.
Thank you, Stephanie, for sharing that. We are having just some technical difficulties this morning with all of our technology. So let's see. Thanks for sharing that, Stephanie. So apparently we're not getting chats through the Zoom. If folks, again, if anyone wants to raise their hand and share with us why you don't think this recommendation is a good idea, we'd love to hear from you verbally. And if there's any questions popping up in the Q&A, Ashley, that we should be sharing, feel free to flag those as well.
Also think the chat should be working now, so apologies for that. And I'm also going to, Dr. Keller has his hand raised, so I'm going to go ahead and unmute your line, Dr. Keller.
First off, since everybody else is going first name, I'm David, not Dr. Keller. They're all doctors here. But the big question I have, I agree fully with what the department is doing, and thank you for that. It's the right thing to do. The other question is, does this affect any of the other measures for which we're using administrative data? The key to all of this is effective attribution and getting the right denominator. And I hope the department is taking a look at the other measures that may have been affected by this glitch.
Thanks, David. And Nicole, if you want to take that one.
Yeah, I replied to Joe's question in the chat on this too, but it could affect other measures. We haven't dug into which ones will be affected, but anything that uses the same PCP definition could be affected. We're digging a little bit more into it, but we were more focused on getting this one fixed right away because it is a pretty big impact. But we'll be digging into what other measures are affected, and we can share that in a future meeting.
Thanks, Nicole. So it looks like the chat is working now. We'll pause for one more moment. If anyone has any dissenting opinions about this solution that the department's putting forward.
So Nina, I'm going to jump in. There were a few questions about how the well child visits affect the KPI for the same measure. We are doing an internal adjustment for that to fix it as well, because it does affect it. So stay tuned for more information on the updates there.
I would add that anybody that's concerned about that, I can put my email in the chat and we can get better information for you.
All right, we're seeing some agrees in the chat. So I'm going to keep us moving to the next discussion topic, but feel free to continue to weigh in on this topic if you've got any thoughts on this. So Zoe, I will pass it to you to continue the conversation.
Thanks, Nina. Just skip it down. So we're going to do a little bit of a review on the point threshold to kind of kick off this next section of the discussion. So this is going to be a review for most, so bear with me, but I think it's important we kind of cover this before we move forward. So how PCMPs earn points to keep their enhanced rate. The points a PCMP earns for individual measures are summed to calculate the APM quality score. Each PCMP must earn the quality score of at least 200 points to receive the maximum enhanced rate. So a maximum of 180 points can be earned from structural measures. And then PCMPs must demonstrate performance on administrative and/or ECQMs to earn the remaining 200 points. Next slide. So all PCMPs have been receiving the maximum enhanced rate for the last several years, so that 104% of the Health First Colorado fee schedule. But the APM payment model intends to provide more funds to top performers. So like in this example, practices A and B. Practices A and B will earn an enhanced rate greater than 104%. Practice C, in this example, will earn less than 104% of the enhanced rate, but is still above the baseline rate of 100%. And practice D will receive the baseline rate. So since practices C and D both earn less than the enhanced rate due to not meeting their 200-point APM quality score, there are extra funds to then be redistributed to practices A and B. Next slide. So here's another view of the same example. This shows that currently the primary care investment is distributed evenly to the 4 providers, A, B, C, and D, and everyone is getting an equitable slice of the pie. The intention of the program is to redistribute the pool of funds based on performance in the APM. So since practice D earns 0 points, they would not earn a piece of the pie. And then practices A and B would earn more of the pie based on being higher performers than practice C and practice D. Next slide. So currently the maximum enhanced rate is 104% of the Health First Colorado fee schedule. That extra 4% on top of the 100% is the enhanced rate, potentially at risk. So beginning this October, for the first time, rates will be changing based on PCMP's performance in the APM program in 2021. So taking all of this into consideration, how the program is set up does not substantially reward PCMPs who go above and beyond the quality of care. So we would like to solicit feedback on the concept of pushing more towards value. So we have a few proposed ideas or mechanisms. So there are a few mechanisms on which this could be done. We could increase the total point threshold for receiving that enhanced rate. So moving up from 200 points to who knows what. We could increase the enhanced rate itself, so more is at stake. So could be more than 4%. Or we could look to explore decreasing the structural measure cap. So it's currently at 180 points, but we could look at reducing that to being somewhere less than 180 points. So we kind of want to gain some feedback from our stakeholders and community on what methods they like to kind of increase accountability and reward, our primary care providers who are going above and beyond the quality of care. So with that, we're going to move over to our next mentee question, and hopefully it's working.
I think we've got it working now. So let's
Great.
try this again. Hold on just a second. So if we go back to Mentee, let's try this again, www.mentee.com. We have the code 26622807. And so the department wants to hear from you all, which of those methods that Zoe just walked through would be most effective to better reward primary care medical providers and improve accountability. So the three options on the table were increasing the point threshold for enhanced rates, increasing the enhanced rate, decreasing the structural measure cap. We also added in, I would need more information to support any of these changes, and I would not support any of these changes for program year 2023. So if you'd like to go ahead and help vote for which method, we do have some questions coming up in the chat. Zoe, if you'd like to help. So our first question is around if we have any data showing actual performance of practices in 2021 and 2022, that looking at that distribution would help us judge if the point system is working.
Yes, so we were hoping we would have some data to share during this meeting, but we are still working with our contractor to calculate the point rate change, or the rate change based on points for calendar year 2021. So we will have more to share with you hopefully by the next meeting, and for sure by our October meeting. So we can definitely share that then, and we're going to use that for sure as kind of guidance on if we were to increase, from 200 points, what does that look like, so that we can make an informed decision. I did do a rough calculation. Obviously, we don't have the data for 2022 since we're still in the middle of the program year, but if we were going to make a decision based on solely how many points a PCMP selected through their quality measures, the average point selection was 295. Obviously, there are some below and some above that, and so I wouldn't use that as a baseline for deciding if we were to change the points from 200, but it does show people select a lot more than 200 points overall. So if we were to change it in the future, it's doable from that perspective only.
Thanks, Zoe. We've got a couple questions coming in through the Q&A. One question asking if we could hear a little bit more about option 2. So that would be around increasing the enhanced rate.
I'm going to pass that over to Jed. If Jed wouldn't mind taking that, he seems to be able to speak to that better than I can.
Yeah, I think I apologize. I am double muted, so that's all fixed now. Actually, I apologize. I don't remember this as part of our discussion as one of the options. Generally speaking, increasing the enhanced rates for all providers would require budget action, which we have not taken. There was substantial budget action. I was trying to find the budget request. We only archived 5 years of budget requests on our website. That's budget requests that originally increased funding for the codes that are commonly used by PCMPs, those that reward cognitive effort, was the budget request that contemplated ACC phase 2. I will say this, that within that bucket of funding, the ability for a provider to get an enhanced rate is relative to provider decreases for those that don't meet the performance bar. So that if the APM becomes more, I guess, quote unquote, difficult, those that nevertheless still succeed with the higher expectations and have the expectation of a higher funding pool to draw from their increases, so that in this fixed bucket of funding, a more difficult APM will mean that those that succeed will get a higher rate increase, but those that get a decrease, those that don't do well will get a bigger decrease. In our stakeholder work, I guess at this point, approximately 4 or 5 years ago, we did contemplate changing the amount that a provider had at risk, which is currently, the decrease can be no more than 4% relative to the standard fee schedule, with any decrease then being reallocated to those that are successful. We did contemplate originally in stakeholder discussions in moving from 4% to then 6% to then 8%. That has 2 impacts. The first is that those providers that don't do well will see more of a rate decrease, but then that means also commensurately that those that do well, that meet the quality bar, will get a higher rate increase. The reality that we face now is that since the average is well above the threshold for performance, the funding pool, because there are no decreases to fund increases for positive providers, or they're very small, I should say, there's none, is that the increase above the already enhanced rate, even for those that succeed, is very small. And the question, I suppose, is this: do people desire to have the APM be harder so that those that are the most successful can get even a larger share of that pie that Zoe showed on the slide a few minutes ago?
All right, thank you, Jed. Welcome any additional questions or comments on what Jed shared. I want to also acknowledge a couple other questions that we have in the chat. So for top performers, is the increase equal for all top performers, or is it variable, with a provider earning 250 points, for example, receiving a higher reimbursement than one with 225 points?
Hi, Dr. Stapp. Thanks for that question. So right now, as the program is, it is equal. So anyone receiving over 200 points, their rate increase will all be equal, regardless of if they had just 201 points or if they had 250 points. It is something that we could potentially look at to do tiers, but it gets very complicated very quickly. So any increase, for any provider over 200 points, their amount of increase will be dependent upon any providers who did not hit 200 points.
Next question around FQHCs. Since they do not have an enhanced rate, how would that option impact them, or would the potential changes not apply to FQHC?
The impact, if the FQHCs are not receiving an enhanced rate, then the changes would not likely apply. But we can discuss further offline.
And then one more question I see in the chat: would increasing the point threshold disincentivize primary care providers who are working toward improving but not able to meet the top tier?
So I think Jed wanted to go back and talk about the FQHC question.
Sounds good. Jed, go for it.
Sure. So every FQHC exceeded the quality bar by a significant amount. The changes the department contemplates are small enough that every FQHC would continue to exceed the threshold. That would mean that there would be no decrease in rate. However, the future is contingent, right? Future performance is unknown, and a more difficult bar at least leads to the possibility that an FQHC will not meet the new higher threshold. But if FQHCs continue the performance in the future that they have shown historically, there would be no rate change.
All right, and then we'll go back to the question from, let's see, Kimberly in the chat around concerns around if the increasing the point threshold, so that would be option 1, might disincentivize primary care providers. Zoe or Jed, do you have any comments on that thought?
Our goal is definitely not to disincentivize providers from participating. I think doing a tier system would be challenging. Those are just some of my initial thoughts, but we would obviously just want to incentivize providers to continue working to, just overall, going back to our mission, providing better quality healthcare to the members they serve.
Yeah, I'll chime in and say that increasing the difficulty to APM comes with some trade-offs. The benefit to that is that a higher level of accountability could be presumed to lead to higher performance, and that's a benefit to our members, who presumably would receive superior medical care as a result for this work to improve accountability to these more difficult standards. However, those practices that aren't able to adjust quickly enough to increase their accountability because of a lack of administrative resources or other reasons would see a decrease. The winners would get more money. Those that don't do well would get less. And so the question, I think, for the group is, are the trade-offs in terms of increased accountability and potentially better performance as a result of higher standards worth the trade-off of having some practices receiving less revenue than they would before? Now, the net revenue to all practices is budget neutral. The proposal on the table is to redistribute that pool so that those that are the most successful get a greater share of it, not without trade-offs. We'd love to hear your opinions about that increase in accountability and the pros and cons to that, of those trade-offs.
So before we take any more questions, I do want to just move us to the next slide. So I want to acknowledge that the Menti is working now. It looks like from this, if we could go back, sorry, Kimberly, just for one moment, I want to just share that it looks like we have 37 participants. The majority of the group is looking for more information to support these changes before being able to vote on options 1, 2, or 3. Of the 3 options on the table, it looks like the most folks are in favor of option 2 around increasing the enhanced rate for primary care providers. So let's move to the next question, and folks can begin answering that while we continue to take questions. What other suggestions or concerns should HCPF consider related to this issue of modifying how primary care medical providers earn enhanced rates? So I know some folks have been putting some things in the chat. That's fine too. We'd love to hear from you in the mentee as well so that everyone can see your responses on screen. So there was one additional question kind of around practices. Sorry, I'm going back. So from Elizabeth, similar questions about impact on practices improving but not meeting a threshold. Has the team been working with Aaron Green to evaluate equity impacts of this change? Any feedback from the department on that question?
So I think we're going to get to this a little further down in our presentation when we go. So maybe we can address that question a little later on, if that's okay.
That sounds good. And then I think we've addressed all the questions in the Q&A and in the chat. Feel free to raise your hand if you've got a comment and would like to speak with us, or if you have an outstanding question. And we're seeing some suggestions and concerns roll in on the mentee. Kimberly, if you want to scroll back up to the top, we can kind of start. So there is some interest again in seeing the current distribution of practice performance. Hard to know how to crank it up without knowing what has already helped. Folks are looking for some more data and information, looking for a thorough, transparent equity evaluation for each proposal before making any changes. Question around whether any of these changes will harm smaller practices, which tend to have fewer resources, putting them at a further disadvantage. I wonder if anyone from the department would like to comment on your thoughts around how any of the options on the table might affect smaller practices.
So I think, again, we're going to get to this like right after we finish this conversation. We'll talk about eligibility for the APM program. So I feel like we kind of address that concern just in a few moments. I know there were some comments in the chat about like rewarding improvement, going from 80 points to 120 versus practices just achieving that 200 point threshold. I think we really need to wait and see what our data looks like from 2021 to see what practices didn't hit their 200 points to be able to make that kind of decision and go and explore that further. So more to come on that topic. There's lots of comments about small practices, so I think we'll kind of get to some of those in a few minutes.
All right, so if we keep scrolling down, let's see what else we've got. Accurate and timely performance data. Currently, pediatric practices have less measures to select. Expanding options for those practices could be helpful. Measures are geared towards larger populations that disadvantage those that work with niche and more difficult populations.
Jed, if you want to, I think Jed wanted to jump in on the small practice topic.
Great.
Sure, I guess it boils down to this. So to the extent that a small practice, so I guess the first thing to say is that very small practices in the ACC are outside of the APM framework. They receive the enhanced funding to the E&M codes, the codes that reward cognitive work relative to procedural work. Those codes weren't changed, just the cognitive E&M codes. The department did change the threshold for participation from 200 members to 500, acknowledging that the smallest practices both may not have the resources to do this to be engaged with this program, and also that the data to measure their relative performance may not be adequate. So the very smallest practices are not impacted by these changes. It seems to be, the assumption seems to be in the question that if very large practices are more successful because of their resources and small practices are less so, then what happens to those smaller practices? I guess I would reframe that question in maybe these terms. HCPF is focused on the quality of care that our members receive. So if the large practices are able to increase quality, that's a positive. A small practice that sees a decrease in rates maybe is less willing to participate in the Medicaid program. Maybe that practice closes its Medicaid panel. However, on the flip side, we've got a lot of patients in a large practice that are receiving higher quality care than they would have otherwise. And the question on the table is that trade-off worth it? And that's, I think, where we'd like some feedback in terms of the answers to the chat.
Thanks, Jed. We do have one attendee with a hand raised. So Kimberly, if we want to go ahead and unmute their line.
Hi, this is Hoke Stapp. I can't tell if I'm unmuted or not.
Yep. Hi, Hoke. We can hear you.
Thank you. So I have a couple of things that I kind of want to get a sense of. Okay, if the average for the points is 295, okay, clearly we've got some room to change that base level. But it'd be really important to look at the distribution of where those points came from and whether or not, how you can adjust that appropriately. So I don't think just knowing that that's too high is enough. We really have to look at that distribution. I am concerned about as we look to, enact some mechanism for changing reimbursement that yes, we want to improve quality, okay, but access is also a big issue, okay. If we make this this program more difficult for providers, that may have less resources, are they really going to then, limit the number of patients that they're seeing, and thus making the access harder, shifting those patients over to other practices? Are they going to be able to accommodate this need? So I think there's this kind of yin and yang that goes there that we got to be very careful about.
Thanks, Hoke, for sharing. I also I want to clarify one point that I think Zoe had mentioned, 295 as a number that some folks are hanging on to. And Zoe, that is not an average performance score, right? That is an average measure selection. Like that's the average maximum that providers could get, is that right?
Correct. That is just a simple, like taking, if a practice, everyone selects between 6 to 10 measures, just summing those up before actual performance has even been measured. The average was 295. Of that 295, the average structural measure selection was 120. Again, just averages, and that's if a practice got full points for all their measures. So we know there's, the close the gap calculation that happens for ECQMs and administrative. So percentages of those full points is common. So definitely not, I know people are hanging on to that 295, so maybe I shouldn't have thrown it out there, but that's just based on measure selection alone, not performance. So we're really waiting for that performance data from 2021 to further guide the conversation.
That's great. Thank you for clarifying. And if folks still have any questions about that, we're happy to take more questions on that, but just wanted to clarify that point. We do have one more question in the Q&A. Curious about barriers that providers are experiencing to achieving these goals and what HCPF and the RAISE are doing, that's the regional accountable entities, are doing to support and provide technical assistance, especially for smaller practices with less capacity. So I know we're going to touch on smaller practices in a moment. Any other thoughts, HCPF team, around what the RAISE might be doing around supporting and providing TA?
I think Jed would like to jump in.
Sure. So I mentioned earlier that this APM was tied to the ACC Phase 2 budget action. And so the rate contract, I think it's like 3 to 4 pages of language around technical support to practices. And so for a smaller practice, what that might look like, well, small Medicaid panel doesn't necessarily equate to a smaller practice. We have some anecdote. For instance, if a practice has a small number of Medicaid members, maybe sees a lot of Medicare beneficiaries, maybe some commercial beneficiaries, the rate support will talk to the practice about aligning the choice of Medicaid selections under this quality measure selection under this APM to be aligned with what the incentives are in Medicare's MIPS program, or what commercial payers accountability is, so that the Medicaid APM has alignment and coordination with what the practice is doing already. And so that's kind of an example of the support that the RAI is doing to help the practice succeed in the APM. That's the tip of the iceberg. We know that the RAI staff spend quite a bit of time in practices providing a diversity of support depending on that practice's individualized need. And it really varies on what the ask is by the practice. Some of it is just education as to what this APM program is and what success could look like. I know that the RAI assistance is often tied to looking at the underlying data and helping practices choose measures where the practice thinks it can be successful.
Thanks, Jed. All right, I'm going to keep us moving because we want to make sure to touch on our third and final topic here around program updates. I know some folks still have some questions and we have some hands raised. We'll be sure to get to those, and we want to also make sure to reserve our 15 minutes at the end for any remaining comments. I also just want to put in a quick request. I know we've got the Q&A going and the chat going and the Menti. So appreciate if we could use the Q&A just for your outstanding questions related to the discussion. And that's a great way for us to kind of make sure that we're capturing those, answering those, getting them answered. Feel free to use the chat if you've got something that's not a question, if you have a comment on something that someone is saying or something outside of the discussion on the Menti, feel free to use the chat. And then let's use the Menti if you are able for the question at hand. If you're not able to use the Menti, you are welcome to use the chat. I know there's a lot of information coming at folks right now, so appreciate your patience and rest assured that we are capturing all of your comments and questions, even if we're not necessarily getting to them in the moment. All right, so Kimberly, let's flip back to the slide to talk through our third program update. All right, and so before we get to the third update, Jed, I don't know if you wanted to jump in with a reminder to everyone related to that last discussion topic.
Sure. And I think this is in the email communication that went out to all PCMPs, at least to the email address that was that we have as a point of contact for that PCMP. HCPF is aware that a very small number of PCMPs do not appear to have separate MPIs for each physical location, as is required by House Bill 1282. An additional number, still relatively small, and this applies mostly to systems with multiple PCMP sites. It appears clear in our data that we see billing where the site is centralized billing through one MPI and is not including on their claims the location where the service is being delivered. That's a problem for the APM, and well, it's not compliant billing, and it turns into a problem with the APM because if we can't identify the site where the service is being provided, we can't adjust the rates as the APM contemplates. And so the department will be identifying certain practices where this billing practice appears to be happening, and we'll be sending out notifications. If you think this applies to your site or your systems, encourage you to take a look at your billing practices to make sure you're compliant with 1282. I can take any questions about that if there are any.
All right, thanks, Jed. And let's move on to our last update around eligibility for participation. So Zoe, over to you.
Thanks, Nina. So we're going to switch gears a little bit and talk about eligibility for participation in the APM program. So in 2021, we received recommendations that new, small, and rural PCMPs needed more support in the APM. And after stakeholder engagement was completed last year, the department made the decision to increase the threshold for participation in the APM from 200 attributed members or 30,000 in billing to 500 attributed members to help alleviate concerns with smaller providers having incomplete APM measure data. So HCPF is also looking to evolve the APM program in the coming year, So this will include more concerted efforts to better engage small and rural providers. So this is kind of taking us into our next topic about eligibility for participation in the APM 1 program. So next slide. So the department made the decision to change eligibility for the program in 2022, and this was a move to get better and more complete data. And it was not to necessarily exclude smaller practices, but this did seem to happen when we changed this attribution. So we might have the common goal of having complete data to have more confidence in the quality measures, but at the same time, again, we don't want to necessarily leave smaller practices out while they're also trying to improve quality. So while increasing the number of attributed members helps ensure more accurate and complete data and removes some pain points for small and rural providers, there are still some PCMPs with data, limited data that could be hurting their payment rate if they don't meet their point threshold. So it is a balancing act, and increasing the number of attributed members may further help support some PCMPs, but again, it might also be excluding some providers who really want to participate. So we're really kind of looking to gain insight from our stakeholders and community on, is there an ideal number of attributed members? How do people feel about this? And engaging, also trying to engage smaller providers. So because we didn't have this conversation with our stakeholders last year, we wanted to open this up for a topic of conversation. So
All right.
next slide.
Thanks, Zoe. So let's go back to the Mentee, www.mentee.com. This is our last use of Mentee for the day. The code is 26622807. And the question for everyone is, should HCPF increase the number of attributed enrollees from, so it's at 500 right now, to be eligible to participate in APM 1? So the options are yes, no, and unsure at this time. So please use the Mentee to weigh in on this question. If you're not able to use the Mentee today, feel free to use the chat to respond. Whether you yes, no, or are unsure about increasing the number of attributed enrollees. We do have a couple questions rolling in and some hands raised. So let's go ahead and unmute Erica if you have a comment on this discussion topic.
Hi, thank you. I just wanted to clarify, is this increase from 500 or increase, or kind of looking back, an increase from 200 to 500?
I think we're looking mostly at increasing from 500.
Thank you.
Or keeping 500. That's definitely, we're not necessarily tied to increasing. We just kind of want to gauge our stakeholders' feedback on the 500 and above or below 500 for some reason.
Thanks. And so Zoe, last year it was 200 attributed enrollees or 30,000 in billing, right? And so it's been changed this year to just 500 attributed enrollees. And now the question on the table is, should that change again? Should we increase the number even higher than 500?
So there is a comment from Julie about how many practices got left out because of this change. I think the answer is about 100. We have about 350 PCMPs that are participating this year. And I think it was maybe more around, it was between like 430 and like 450 last year, I want to say. And there is an option.
Yeah,
Sorry, go ahead, Jed.
That is those numbers are ballpark accurate. I just wanted to clarify that excludes the FQHCs and all of their sites. So we're talking about the non-FQHCs. Of course, FQHCs participate regardless of size of a particular site because their data is pooled at the center level. One of the takeaways that should be noted is that small practices, because by definition they have small Medicaid panels, the number of members who are seen by these small practices is relatively low. And so even though the small practices make up a fairly decent share, still a minority, but a fairly decent share of the total PCMP count, it's worth noting that the number of members that they care for, the smaller practices, are a very small share of the total. We have well over 1 million people attributed to PCMPs in the ACC. And if you take a practice with 200 and another practice with 200, you can add up to 100 practices that don't participate in the APM that continue to receive enhanced reimbursement based upon that budget action from 6 or 7 years ago, but that don't participate in this quality model. So the members that are outside of the members, if we want to think about that perspective, that are outside of this quality model are in the single-digit percentage. It's not. We're bringing it up because it's still worthy of focus, but the impact in terms of overall Medicaid membership is relatively small. However, these folks don't need to be left behind, and we're trying to figure out what to do and would like input and help.
All right, let's move to the next Mentee question. So it looks like the majority of the group is not sure. And then we had, I think, 19 folks voting for no and 9 for yes. So let's open up to this next question around how can HCPF better engage small and rural providers while addressing the need for sufficient volume to succeed in value-based care like the APM program. So the department would love to hear from you, your thoughts and suggestions around better engaging small and rural providers. And if you can't use the Menti, you're welcome to plug your comment into the chat. So we've got one comment in the Menti so far. Do not automatically assume small equals low quality care and large equals high quality care. Lots of factors play in. Two prominent factors are staff turnover and number of other payers. Small practices serve a very important role in rural and even some urban and suburban areas. Need a way to allow them to improve in a way that works for them and can avoid EHR if they do not have it. More comments coming in. Providing incentives or funding to support rural or small providers with better performing EMRs. Finding ways to provide more upside to providers who care for a large percentage of members in their payer mix. Designing APM specific for small and rural practices as opposed to just excluding them. Allowing providers to opt in. These lives matter even if it's a small percentage of the whole. In a member-driven, equity-driven stakeholder process, HCPF could ask rural members what they need from a quality system. Keep scrolling. Allowing small practices to cluster to create a substantial enough denominator for measure stability is an idea. More on allowing practices to opt in, which I think, Zoe, maybe if you can clarify that practices can opt in currently. Is that correct?
That is correct. So if a practice, say, has like 450 attributed members, this is obviously just an example, they can petition the department to participate in the program. The department is really working to gain, more complete data, especially around core measures for reporting. And so we do reserve the right to allow them to participate or not. If we look at their data, it doesn't look like it's going to support them in this program. So they don't have the denominator for ECQMs or some administrative measures that they chose. Our goal is not to hurt them, because if they don't meet their quality goal, they could receive a decrease in that enhanced rate. So that is what we're looking at because we want to ensure a success in the program. Similarly, we do have an opt-out option. So if you're right around that 500 and you feel like your data is not going to support you in the program, you can petition the department not to participate. Go ahead, Jed.
That's right, Zoe. And I wanted to provide maybe a color commentary through an example. Physician, say, fresh out of residency, doesn't have baseline data because they didn't have independent practice in a prior period. That's a perfect example. This physician maybe takes excited about serving the Medicaid population, has a panel above 500, lacks that sufficient historic data. We're not going to punish that brand new physician in independent practice who's eager to take Medicaid. There is an opt-out provision to account for a circumstance like that. Zoe's absolutely correct.
Well, thank you to everyone for your great feedback in the mentee. Rest assured that we are capturing all of this. We will be sharing this with the department after the meeting and can circle back on all of these comments at a future meeting. So let's keep moving to our final agenda item before we get to public comment. So I'm going to just give me just a second here. So let's turn to progress on a few of the 2021 stakeholder recommendations. And I'm going to pass to Dr. Walsh to check in on what the department is doing around addressing racial and ethnic disparities in value-based programming.
So I just want to spend a few minutes talking about this important topic. Last year, we did receive expected feedback regarding and advising us that it's important to consider racial and ethnic disparities in how we design this program. And we do in fact agree. I'm not going to say today that we have fully developed a solution, but I do want to update you on what we've done in the interim. Since we spoke last, there is now a Department Health Equity Plan. You can see a picture of it there. It is available on our website. And it outlines the, I'll say, department-wide efforts and how we're going to approach in the coming year basic disparities and try to help to decrease them. With regard to this program, I would just say there's really at least 3 different threads of how our work relates to it. The first, I think when the recommendation was made, it was made in the context, and we're not going to get into, I'll say, measure selection this year, or during this discussion, but I think it was made in the context just of metrics. And what I'd like to say along that front is we are going to consider that basically racial and ethnic disparities and others, individuals with disabilities. I could go on. There's some other areas as well in how we do measure selection in particular. I'll say one of our guiding lights as we do that, and as we look at this program, and we'll have these future discussions, our metrics, the plan has some metrics we intend to focus on from a racial and ethnic disparity perspective, and we'll consider that as we develop what we do and what we tell you about in our future discussions. The other, I'll say, guiding light in terms of how we're going to look at metrics is alignment with other programs. And so we are going to very much consider this issue. We're also going to consider the multi-payer collaborative work as well, and what we intend to do with APMs, I'll say, in the out years. So this is important to us. We are going to look at the plan as one of the key, I'll say, starting points for what measures we select. I also think I just want to acknowledge the fact that I think people, and we are hoping to get to a different level where not only is it about what metrics you select, but how you actually perhaps have methodology in them to actually reduce disparities based on race and ethnicity and other factors within those individual metrics. We did some of that with our COVID work with the RAISE in terms of incentivizing how they focus their COVID efforts. And while our overall Medicaid vaccination rate was significantly different in the state by almost 30%, we did substantially narrow, I'll say, those disparities in performance. We would have liked the overall performance to be much higher. So we have done some work in how you can take a metric and incentivize reducing it, for instance, narrowing the difference between groups to some percentage. I'm not sure we're ready for that this year. We haven't had the internal conversations about that, but that is an option. We also now have the ability to evaluate our metrics for race, ethnicity, and other factors, particularly with regard to core measures. However, I'll just be frank with you, as mentioned earlier, we have a lot of work to do, both internally and I think our providers do with regard to how they provide metric, I'll say, performance data to improve our ability to measure core measures, which at a minimum, we actually have to report to the federal government mandatorily in 2024. So these are some of the things we're thinking about. We continue to think this is a very important issue. We are going to look at the report And we're also going to look at alignment. So Nina, I'm going to hand it back to you. Actually, it looks like I'm handing it to Zoe next, if you agree with that.
Thanks, Dr. Walsh. So another recommendation that came out of stakeholder engagement last year was exploring ways to ensure all Health First Colorado members are being reached and receiving care. So the department is continuously working to align measures across different programs that we run, such as the KPI, Behavioral Health Incentive Program, just to name a few. And we continue to work on alignment across managed care organizations as well. So some ways that we do this is quality measures also have different continuous eligibility requirements so some could be capturing different subsets of members. And we still look at statewide data, even for providers who are not participating in the APM program. So we are looking at data across all Health First Colorado members in the APM and not, as well as trying to capture them in different program areas. And if there's any questions on this, I'm happy to take them. Otherwise, I'll pass it back to Nina and we can move on to public comment.
All right. So we've got the remainder of our time together today for public comment. So if you didn't get a question answered or have something else to share, we'd love to hear from you. You may share comments and questions verbally or in the chat. So if you want to raise your hand, we can unmute your line. We ask that prior to sharing, if you could share your name, organization, and disclose any financial interest, if appropriate, if you're talking to us over the line, we would appreciate that. If you have a comment to share in the chat, please be sure to select all attendees and panelists to send the message to. And let's get going. So looks like we have Stephanie. If you want to go ahead and share your comment with us.
Thanks. So my name is Stephanie Sandu. I work at Stride Community Health Center. I'm our Director of Clinical Quality and Clinical Risk Mitigation. I have no financial disclosures. So I wanted to highlight the importance of data visibility and transparency. It's been incredibly frustrating with some of the claims-based measures, especially the medication adherence measures, to actually have data reliability and have visibility to performance in real time. I don't think we can hold practices accountable financially for performance and measures where they don't have the ability to really intervene because they don't even know where their baseline data is. So I'm really excited about the work you guys are doing to standardize measures across the board. I think that's so important. But I did also want to highlight a concern I have, especially with us moving towards an expanded spectrum of incentive-based payment, because as you was acknowledged, that's going to incentivize practices that are doing better, more, and potentially lead to decreased payment for those that are doing poorly. I don't think we're in a state right now with the measures that we're reporting on where we can say that equity has been completely addressed. I work at a practice that takes care of patients who are largely uninsured. Even our Medicaid population is largely refugee. There's just such a significant amount of barriers to them obtaining health goals that no matter how much care management I provide, we know that SDOH influences health outcomes to such a degree that I worry us moving towards having more incentives for practices that are doing better. We're going to be incentivizing practices to take healthier patients. And we just have to acknowledge our Medicaid population is not uniform. The reality is there's Medicaid patients that are much more better resourced than other Medicaid patients in the state. And so that's why I just really want to press that. I think making no changes and not further exacerbating that disparity is really important.
Thank you, Stephanie, for sharing. Thanks, Stephanie, for sharing. We'll go next to Kayla Ortiz.
Hi, so I'm from Kids First Healthcare. I'm the revenue manager and with as well as quality and compliance. So for us, my concern is just how it affects school-based health centers. We have 2 community clinics that function year round, but we take a large mass of Medicaid patients in those schools. which would help us reach our numbers across the organization. I mean, we don't want to pull them out of school to get them into our primary clinic for them to meet their measures, but we also don't want to be, like, we obviously want to opt in for all of our clinics, including our school-based, but that's where we cross paths, right? So like, it's not a clear-cut line. If our schools are shut, then they're going to have to go to the main clinic, and we just want to make sure, obviously, across the board, we're reaching all APM measures. So I think it would be nice for school-based health centers to be considered too, and how it would affect our panel. And then
Thanks,
just
Kayla.
one more thing. And for our large population, right, we know that education is largely impacted by their health. So I think that's why school-based health centers for pediatric is so important, right? We're trying to keep them in school, keep their mind healthy, everything healthy as a whole. And so, you know, school-based health centers are extremely important in all around health for children.
Thanks, Kayla, for raising that. And next we'll go to Hoke.
Hi, thank you. I want to reinforce some of the things that Stephanie said. I think that we really do have to be very careful about ensuring that we are trying to accelerate the things that are most important in achieving the goal of better care. And in pediatrics, number one, that is just, you have to have well care visits, okay? And then number two, probably especially in this population, we need increased emphasis on our social determinants. Now, the way that we have our point structure devised, I don't think that we're necessarily achieving the goals that will move this forward. And it may be that we really do need to revisit, you know, how we want to, you know, proportionally value the various metrics that we're looking at that we think are important. Okay. And I think the bottom line on that is that for those patients that really that need the more care, if we aren't really seeing them, if we don't know their well care visit rate, and we don't know what the circumstances are for that family, it's impossible for us to improve their health. Thanks.
Thanks for that comment. All right, I don't see any other hands raised for verbal comments. We do have some comments coming through in the chat. From Joe English, the public health emergency lock-in means there are still members who are assigned to Medicaid or CHIP Plus who have private coverage. Not sure how many people this represents, but anecdotal info from primary care medical providers seems to indicate it's a significant number. So expecting all members to be engaged in care may not be appropriate given the impact of the lock-in and transition of some of those individuals to other providers for care. Comment from Jennifer Ammerman. Recognize that a homogeneous clinic may have better performance even with comparable Medicaid and uninsured percentages. Comment from Jennifer, something we've seen with our rural health providers is that when they bill with UB04, all of the CPT codes they use are being dropped entirely from the claim. So for key performance indicators, they are not getting any credit for what they do. This should be corrected for KPIs. However, it would have a huge impact on their performance for APM administrative measures if that continues to happen. We have a question from Nate Kohler in the chat. Has there been any consideration to reduce the number of measures that practices select? 10 goals at one time makes it challenging to dig deeper on any one measure without ignoring other measures chosen. It's a great question, Nate. We'll capture that. And Jed, if you want to jump in, go for it.
Sure. In terms of rural health centers, so I guess first of all, the APM is a payment modification program, right? Based on measured performance. The whole concept is that rates go up or down. Rural health clinics that bill on the institutional claim receive a federally mandated reimbursement amount, and so we're unable to change their payment amounts based on performance. So two things: if there's one of those clinics that's inadvertently being assessed for performance in the APM, reach out to us and let us know so that we can fix that. The second thing is that we've had many conversations about what we can do to support rural health clinics that don't involve a payment change that we can't make under the federal rules around reimbursement. And if there's any thought or feedback in terms of that support, we'd love to hear it, because there's a significant share of our members in rural areas receiving services from those clinics. And we'd like to have the same ability to support those practices as we do for those that aren't certified as those rural health clinics by the federal government.
Thanks, Jed. All right, and with that, I think we're going to close out today. So if you didn't get your comment or question in, please feel free to continue to reach out to Team CHI at focusgroups@coloradohealthinstitute.org. We truly welcome your comments and questions and do our best to get them answered as quickly as we can and connect you with the right folks at the department. We have our second community forum in this series on Thursday, September 22nd, same time, 7:30 a.m., where we hope to dive into some program data, measure set, and point updates. A reminder that you do need to register individually for each of the 3 forums. So make sure that you are registered for that second and third forum, which is going to be taking place on October 13th. And we'll get you out of here. Thanks so much for your time today. We appreciate all of your feedback and look forward to continuing to hear from you in the future. Take care.